Is my screen being shared?
Yes, sir. We are waiting for it.
It's opening up. It is.
We will wait. We will wait.
Yeah, I think it is.
Yes, perfect.
Fine.
So, okay. You make it full screen, sir?
Yeah, I'll do full screen, sir. Yes.
So that's great. Good evening. I think we are a little delayed, but it's okay.
No
So
problem.
I warmly welcome both the postgraduates for the day, Dr. Jujar and Dr. Rahul. Dr. Jujar is kindly contributed by Dr. Ishan Chaurasia, who is a professor himself from ABV GMC at Vidisha. Dr. Jujar is from MGM and MIH hospitals in Indore. And we have the other doctor from Dr. Rahul Dameja. He is from Lady Hardinge Medical College, New Delhi. And I thank Dr. Deboshi Sharma and Professor Tudu for giving Dr. Rahul Dameja here. And friends, being a hernia session, I have the privilege of having one of the international hernia exponents here, Professor Balasubramaniam Ramana. So it's a privilege because I would say students should understand from the basics to the most recent trends in the hernia. That's the reason we have the global exponents here. And I also expect Dr. Jignesh Gandhi and Professor Tudu to join us. Professor Deboshi is still with an emergency who is expected to join us shortly. Friends, those who have joined, and I also welcome all our senior faculty who have been with us in the journey for the last 2.5 years. And many of them have been with us for the last entire 133 sessions, which I've been doing on all Fridays. So the way how it happens, this session is, technically it is an hour-long discussion for each case. The student is first gently allowed to go through all the clinical history part of it. Then we has a pause with a brief summarization. Then the invited faculty take precedence to ask questions and they can give their comments if the student is grossly missing out on any important finding or any important history as such. Then as we complete the clinical part, like history part of it, then we move on to the clinical part of it. Then we have a non-stop presentation by the student till the end of coming to the diagnosis. And we also have imaging for discussion. The initial discussion will revolve around the way he has arrived at the diagnosis, how he is going to manage the patient. Then, of course, we share about 10-15 minutes about management and the most recent developments in that specialty. So this is how the session is going to go. So I would recommend the invited faculties and our own standing faculties of this PG clinics to take over. And I wish good luck to both the postgraduate residents. Can I have the honor of inviting Dr. Jujar to start his presentation? Good luck to you, Dr. Jujar. Ishan sir, I think still it's not made full screen. Can we make it press F5?
It is full screen,
on
sir.
On the right side, you make it a screen like a slideshow.
Yes, yes.
Can you? Perfect, sir. Perfect. You are done. Dr. Jujar, all yours. All the best to you.
Thank you, sir. Good evening, respected consultants. Today I'm going to present a case of a patient that presented to us in emergency. She was a 48-year-old female who was a housewife and a resident of Vidisha. Presented to us with the complaints of swelling in abdomen since 15 years, and there was complaint of not passing motion and flatness since last 3 days. Also, there was 3 episodes of vomiting, which was bilious in nature, and there was pain in abdomen since 1 day. So the total, the history of presenting illness was the patient had been asymptomatic since the last 15 years. Initially, she noticed a swelling which was in supraumbilical region. Initially, on coughing or while passing motion, it would increase and would gradually decrease on its own. And over 15 years, it progressively increased in size. And she could feel it while lifting weights and on coughing and on standing. And while she was lying down, the swelling would reduce. And in the last end, this patient had complained of intermittent obstipation. And since last 3 days, she was not passing motion and flatus. And there were episodes of bilious vomiting accompanied by abdominal pain. The pain was dull aching in nature and continuous type of pain and was not localized to any specific quadrant of the abdomen. The patient did not have any significant comorbidity, and there was no addiction history of the patient. There was no history of any chronic medical illness, no history of hypertension, diabetes mellitus, pulmonary tuberculosis, or any COPD. In past, the patient had not undergone any surgical intervention also. Personal history was also not a very crucial, or there was no significant finding in it. She was having 2 offspring and both were from normal vaginal delivery. And there was no similar significant past family history also. The patient did not seek any treatment in past for the abdominal lump because it was not causing any pain or other obstructive symptoms to the patient. So to summarize it, there was a 45-year-old female housewife that presented to the emergency department with complaint of swelling in the abdomen, which has recently become irreducible and was associated with few episodes of bilious vomiting. The patient was unable to pass motion and flatus and could not tolerate diet and had abdominal pain since 1 day and did not have any associated comorbidities. On examination, vitally the patient was stable. The pulse was 96 per minute. A little tachycardia.
Dr. Jujar, should we go back to the history? Dr. Jujar, so can we go back to the history, please?
Sure, sir. Sure, sir.
Yes, sir. Yes, sir. Should I go to the history summary, sir?
Right from the beginning, sir, please.
Okay.
Is there any history of
Go to the first
operation in
slide
this
of the
patient?
presentation, sir. The examiners usually ask questions based on it.
Is
Dr.
there any
Ishan, I
history?
think you go to the complaint slides, chief complaint slide. Perfect. Examiners, please take over.
Is there any history of operation in this patient?
No, sir. She was not operated for anything in the past. There was no surgical history of the patient.
So, if you think the patient has got a swelling which was coming up and it was going in on lying down, so
Yes,
what was
sir.
your diagnosis based only on the history?
So usually it could be an abdominal lump or it could be hernia of the anterior abdominal wall.
Which lump will go inside when the patient lies down if it is not a hernia?
Dr. Jujar, you should just straight away come up with hernia. I mean, you should not give 2 options. Your first option was a lump, which sir obviously will catch. You just say it's a hernia, right? Don't be so hesitant.
And so if it is a hernia, what type of hernia it is?
Sir, it belongs to a group of anterior abdominal wall hernia or ventral hernias.
What is the difference between a ventral hernia and an incisional hernia?
Sir, ventral hernia is a broad term and it includes a wide variety of hernias like epigastric hernia, umbilical hernia, paraumbilical hernias, infraumbilical hernias. Incisional hernia is a type of ventral hernia.
And what is the incisional hernia?
Most important, it is an itero.
What is an incisional
Incisional
hernia?
hernia is whenever a patient is operated. Sir, incisional hernia is protrusion of the abdominal contents from a previously given surgical incision.
So it is only the surgical incision which makes the incisional hernia? There is no other reason for the incisional hernia?
It could be due to penetrating injury or like a stab injury. From that side also herniation could develop.
So they are also the causes of incisional hernia. It's not only iatrogenic one. They are also the causes of the incisional hernia. Now, based on your history, only. What do you think? What type of hernia it is?
Sir, it is a paramyumbilical hernia.
No, is it an uncomplicated hernia or it's a complicated hernia? Only on the history. Yeah.
Sir, it is a complicated hernia.
Okay. What
So because
complication has occurred?
the patient was having, sir, patient is presenting to us with obstruction now. The hernia has obstructed the.
But you have not
outflow of
mentioned
the bowel
anywhere
content.
the distension of the abdomen. There is no history of distension of the abdomen is there, isn't it?
There was a
So it
very
is-
huge swelling in the abdomen, and the patient was a little hefty. The patient was a little hefty, and there was a big swelling of well crossed 10 centimeter. So there was no gross distension at that time.
No.
When the patient presented,
in
there was
history. Dr. Jujar, we are talking of history only right now. Have you mentioned the site
patient
of?
did not
Have you mentioned the site of
distension of the
swelling?
abdomen.
Have you mentioned the site of swelling? Only abdomen is it? Do you think it is enough? Should you
It was
mention
in the
the
umbilical
site?
region. Mainly, yes, sir, I should have mentioned it.
How will you differentiate between obstructed hernia and strangulated hernia? Only on history. Okay, we are only on the history.
Sir, the obvious sign of obstruction would be present in both of them. But in strangulated hernia, the patient would be having features of inflammation at the local site. There would be redness, local rise of temperature. There would be history of fever.
Dr. Jujar,
That
Dr.
can be
Jujar,
inflamed hernia. So then that
Dr.
can be
Jujar.
inflamed hernia, isn't? You know what is inflamed hernia? And do you think all the strangulation
Sir,
will have the
inflamed
obstruction? Dr. Jujar, do you think all the strangulated hernias have obstruction?
No, sir. All strangulated hernia may not present with obstruction at that time.
No, all strangulated hernia will have obstruction. It will not have all the inflammatory signs, all the pain, what you say. Is it possible to clinically differentiate the hernia from obstruction to the strangulation?
So clinically, there will be localized changes at that site in a strangulated hernia. It will be there will be a lot of tenderness, redness, and there will be raised temperature. The classical signs of inflammation would be present at that site when it is strangulated. In obstructed, there won't be such signs of inflammation because the inflammation hasn't set in yet.
Dr. Jujar, can
Give
we go to the next
the
slide?
examples of cases with strangulation without obstruction. Give the example of strangulation without obstruction.
Sir, usually when the patients of volvulus present to us,
In volvulus, there will be
we usually
obstruction will
present
be
with
there.
the symptoms of strangulation.
What is the commonest content in the omental sac, in the hernia sac? What is the commonest content in the hernia sac?
Sir, omentum.
Can the omentum be strangulated and the patient is not obstructed?
Yes,
Can it
sir, it could
happen?
be there.
If there is only
Yes.
appendix inside the sac is there, which is strangulated, will the patient be obstructed? If
No,
there's a
sir.
mucus diverticulum is there, will the patient be obstructed? It's a gangrenous mucus diverticulum.
No, sir.
If the rectal hernia is there, the small part of the bowel is strangulated, but still the patient will not be obstructed. So there are so many causes of strangulation without obstruction. Okay.
Dr. Jujar, can you go to your next slide, please?
Prashant, can you advance the slides, please? Hold back, sir. The history slides. No, sir. So the history slide.
History.
Second slide. Stop.
Right. Okay, Dr. Jujar, have you
Next
asked
one,
about
sir.
any history of
Next slide.
Yes, sir. Please stop there, sir.
any history of bleeding per rectum, any altered bowel, diarrhea? Is it important to know whether she's bleeding from the gut or not? If you think she's
Yes, sir. Sir, it
so
is important.
that portion is missing in your history. There's nothing about her motion at all. When did she last pass her motion? About 3 days back. So was it normal? That has to come out. That is important.
Usually
Okay. So by history, so can you give us a working diagnosis, please?
Why do you, Sujar, you think that on lifting the weight and passing stool that the hernia is increasing in size?
Sir, usually when there is because of the increase in the intra-abdominal pressure.
What is the normal intra-abdominal pressure?
The normal is from 0 to 5 mm of mercury.
So why the pressure increases on coughing or when the patient is straining? What is the mechanism?
On coughing or straining, the intrathoracic pressure increases.
No, that has nothing to do with the intra-abdominal pressure.
Pushes the abdominal contents downwards.
Diaphragm pushes down, anti-abdominal.
The size of the abdominal cavity reduces.
Okay, the volume is indirectly proportional to the pressure. So when the volume is reduced, the pressure is increasing. So that is why you are getting the
pressure increases.
Increase in size. Okay, go ahead.
Yes.
Can we go to the examination, please?
No, what is your provisional diagnosis with the history?
The provisional diagnosis is an obstructed ventral hernia, most likely perambilical hernia. Obstructed.
Is it just obstructed, or can you then? How do you explain the pain then? How do you explain the pain? Why is it painful?
You are using
what are the causes of pain in
terminology.
intestinal obstruction? What are the causes of pain in intestinal obstruction?
There is the proximal bowel is distended, that causes the pain.
Okay, because of hyperdynamic peristalsis. Okay, what else?
Dynamic obstruction, adynamic obstruction, sir, is asking about that.
What are the other causes of pain?
Mechanical, amechanical, just explain that.
So the obstruction could be a dynamic or adynamic one. In a dynamic obstruction, there is something that is occluding the lumen of the bowel.
Okay, we've got that. That because of distension of abdomen. Any other cause of pain in obstruction?
So there can be visceral pain when there is
No,
strangulation.
I don't want to know the types
No,
of pain.
what you said initially is only the visceral pain. When the bowel is distended, what you are going to get is only the visceral pain.
Visceral pain. Any other kind of pain? Cause of pain?
Yes.
In this patient.
Does ischemia cause pain?
The content of the bowel.
Does ischemia cause pain?
Yes, sir. It causes sharp shooting type of pain when the
We're not talking of types.
ischemia sets in.
Look, Dr. Jujar, when we ask a question, don't try to give extra information. Just give the information what is asked.
Yes.
We asked you whether there's pain, you say yes, ischemia. Type of pain was not asked. So don't, you may just get caught in there, okay? So just say that because of ischemia, there is pain, right? So there are two reasons here.
Yes,
so
sir,
you think this patient is having ischemia then?
Sujar, you have put as a supraumbilical swelling. Suddenly you are bringing it as a paraumbilical hernia. What is the logic behind that? What is paraumbilical hernia?
So in paraumbilical hernia, the defect is just lateral to the umbilicus.
5 centimeter. If it is 5 centimeter lateral to
Pardon,
the
sir?
umbilicus, you will still call it as a paraumbilical hernia? Because in the history, you are putting it as a supraumbilical hernia. Then suddenly you are making a diagnosis of paraumbilical hernia. Is there any specificity for that? So the defect is within 2 centimeter of the umbilicus only, you can put the term as a paraumbilical hernia. When you supraumbilical hernia, even if it is epigastrium, you can call it as a supraumbilical hernia. So what was your original swelling?
The original swelling was in a supraumbilical region within 2 centimeter of the umbilicus.
Okay.
So what would be umbilical hernia then?
Sir, umbilical hernia has a defect in the umbilicus, which is present since birth, but it obliterates usually in the first to second weeks of birth.
Look, Dr. Jujar.
And in
Look, Dr. Jujar, hang on.
that
Dr. Jujar, we didn't ask you about how it happens.
yes, sir.
Just tell me what is an umbilical hernia.
Okay, sir. Sir, herniation through the umbilical orifice is umbilical hernia.
So all the walls of the umbilicus have to be involved to call it umbilical hernia?
Yes, sir.
No.
The fibrous margin of the umbilicus.
Right.
Umbilical
If a portion of the umbilicus is involved, even if a portion of the umbilicus is involved, it's called umbilical. Okay.
Your patient is relatively a middle-aged woman. Do you think that suddenly the umbilical hernia will develop at the age of 35 to 40?
No, sir, she was having complaints since last 15 years.
Okay.
It
What
was
was the
not a
age?
new onset. The obstruction was the new onset in this patient. Sir, she presented to us at 48 years of age.
Umbilical hernia, practically, it is a very early part of this. It is congenital in origin most of the time. So you don't get in the later part unless it is a ventral hernia, incisional hernia, if you are beginning of the scar. So here there is no history of incision. So there is no possibility it could be an umbilical hernia. Either it could be a paraumbilical or epigastric hernia. So now the patient is presenting you the pain.
There are 4 types of umbilical hernias, Dr. Jujar. One is an exomphalos, the other is a congenital umbilical hernia, there's acquired umbilical hernia, there's a paraumbilical hernia. So this is a case. All right. So don't get confused, just have a glass of water and let us continue.
Okay. Go ahead. Go to your clinical examination.
Yes, sir.
The general examination, come on.
Sir, in general examination, the patient was examined in a room light with informed consent. The patient was afebrile at the time of presentation. The pulse rate was 96 per minute, regular and rhythmic. The blood pressure was 114 by 76 mm of mercury. The respiratory rate was settled, it was 16 per minute, and the breathing pattern was thoracoabdominal. The patient was a little hefty on the hefty side. She weighed 80 kgs, and the height of the patient was 160 centimeters. On general examination, there were no pala, recurrence, cyanosis, clubbing, or any lymphadenopathy. So on local examination.
Now, what is our BMI? Have you calculated the BMI to say that don't use the word just obese, just she's on the hefty side. These are not the terms which we are used as a surgical side. We have a definite definition whether the patient is a pre-obese or obese. So you need to put the BMI, you have to find out and say the presenting feature. And your pulse rate is 94. What does it signify?
Sir, it is a little toward the tachycardic side.
But you have not mentioned about the temperature in the general examination.
So the patient was afebrile.
No, you need to say that. No, when the pulse rate is high, and especially you are talking about a case of a one-day dual obstruction, if there is any signs of peritonitis, So that will be manifested with the tachycardia, tachypnea, because already you have a tachycardia, but there is no tachypnea. There is a temperature also we need to mention in the examination, because this is, though it is a 15 years old, now you are going to present a case which is as acute abdomen. It is presenting with a 1 day old sudden vomiting, sudden pain. So your features related to that you should mention. This is not a routine chronic case presentation. Okay, go ahead.
Yes. Sir, on local examination, first we inspected the patient. On
No, we have
inspection, the swelling
repeatedly said,
was
please remember,
approximately
Sijor,
10 to 50.
Sijor, don't use the term local examination. That has been repeatedly in every class, it has been mentioned. What you are going to examine, you should say. What you are going to examine? You are examining the abdomen. So use the term examination of the abdomen, examination of the inguinal region. Don't use the term as a local examination or
Yes,
general examination. This is not a accepted norms for the examination pattern. So you say you are going to examine the abdomen. That is what we want to see. Go ahead.
Okay, sir. Sir, on examination of abdomen, first we inspected the abdomen. So there was a swelling of 15 cross 10 centimeters, mostly in the umbilical region, extending to the epigastric and the iliac regions. There was eversion of the umbilicus. There was a little skin discoloration present in the umbilical region. The swelling would increase on, there was cuff impulse present on inspection, and there were no apparent dilated or tortuous veins.
User, you can remove this slide here. Yeah, just change that slide, because you're not covered the private parts. Okay, you should have covered the private parts for this patient.
Sorry, sir.
No, as it is online and online class, that is why sir is asking. No, on physical examination in what, it's okay. Otherwise, our YouTube channel will get blocked. That is the only reason. Carry on.
Sir, on palpation, we confirmed the inspectory findings. The swelling was approximately 12 into 10 centimeters. There was no local tenderness or rising temperature. The cuff impulse was present. The swelling could not be reduced, and there was no fluctuation in the swelling. Sir, on percussion, a tympanic note could be percussed over the swelling, and bowel sounds was appreciated on the abdomen. Sir, in other systemic examinations in cardiovascular system, the heart sounds were present, though no specific murmur was present. In respiratory system, the trachea was in the midline. The bilateral air entry were equal in both the lungs, and no added sounds were heard. In nervous system, the patient was conscious oriented and was cooperative. The power in all the limbs were 5/5, and reflexes were normal. So then we managed
Before investigation,
the patient simultaneously.
Before investigation, you come to the clinical examination, inspection. And any inspection do not start with the swelling. No, there is a certain protocol you need to follow when you are presenting a case of inspection. And you need to present what is the shape of the abdomen. What is the...
Move the picture. Yes, thank you.
Yeah, that you need to go. Don't present as if only the salient features you want to. This is not only examination. This is also a teaching schedule which you are following. So we want to go ahead with a practical method or appropriate method with which you are going to present a case. So straight away you are now starting about a swelling. And again you are using the term supraumbilical swelling. Because it is in the umbilicus and it's the paraumbilical region. There is a swelling. It is that infraumbilical also we are seeing the swelling. So you must be specify what is described the swelling and associated with the patient is whether it's obese, whether the abdomen is distended, if there is associated features there. Second, you are saying that you are able to see the cough impulse, but the swelling is irreducible. How in the irreducible swelling you are experiencing the cough impulse? When the swelling is totally not irreducible, but what is happening?
There are 6 cardinal signs for inspection. We have to see the contour of the abdomen, the skin of the abdomen. We have to inspect the hernial orifices, whether there is any peristaltic movements, any pulsatile swellings or not. It just got a little bit confused. So I'm sorry on his behalf, but it's all fine. And there was no cuff impulse. There was no cuff impulse.
No, he said.
How do you define the cuff impulse? What is a cuff impulse?
So the protrusion of the hernial contents when the patient is asked to cuff.
So if somebody
From the
already
hernial
had a
side.
swelling there, then can you elicit the cuff impulse?
Without reducibility, if you are eliciting cuff
Not
impulse, then entire abdomen will be out only.
Okay, cuff impulse has got 2 components. There is no swelling and a swelling appears, or a swelling is there which increases in size. So both are cuff impulse here. Okay.
Can you think of any other condition where which is not a hernia and you still get cuff impulse? Cuff impulse is not only seen in hernias, it's seen in other conditions also. Dr. Jujar?
Yes, sir.
Where else can you get cuff impulse? It's not a hernia.
Start from the head and go down.
Yes.
Sir, in meningomyelocele, we can see cuff
Good. Okay.
impulse. Meningocele and meningomyelocele.
In the chest.
Chest wall.
Suppose the patient is having infection in the pleural phase, what will happen?
Pardon, sir?
If he has an infection in the pleural space.
Pleural space.
And then with some swelling.
Yes, sir, it could be present with.
What is that?
Sir, if it is a draining empyema could present with
What
Not
empyema?
draining.
What empyema?
Subcutaneous empyema.
What is the name of that condition?
Subcutaneous empyema, that is a.
There is a specific name.
Empyema cannot be cutaneous, no.
Necessarily, you have to answer that word.
Sorry, sir, I'm not able to recall.
It was a tough nut to crack, sir. It was a tough nut to crack.
This sir is giving the most important word needed for your answer.
It's called empyema necessitans. Okay.
Resistance.
Can it be there in the neck? Can you get a cuff
Sir,
impulse in the
hygroma
neck?
could present, sir, in hygroma.
Hygroma, no.
Dr. Jujar, I just want to tell you, look, you're digging your grave, you're getting into this trouble because you're answering simple things. You're not answering simple things like cuff impulse. You made that mistake and look where it's brought you down, isn't it? You said in an irreducible there's a cuff impulse and look what has happened. So basics you have to get right in your examination. Otherwise you'll end up in this kind of trouble. And
You have a solely which is the cough impulse is positive, but why do you want to look for a fluctuation in that solely? You have written as the fluctuation was negative. Now, what prompted you to look for fluctuation? Do you have anything in the mind that the solid solely will come out? What we expect on the postgraduate is you are limited time. You have to do examination within 45 minutes and do only what is necessary, what is logical. Don't try to do all that is given in that test. And when you are for a hernia, normally will you do a fluctuation test?
No, sir.
Okay.
Okay, just for your information, cuff impulse in the neck will be in the laryngocele. And then there are 2 types of cuff impulses. One is called an expansile cuff impulse, and then it's called a non-expansile cuff impulse. Now tell in the inguinal region where you get the expansile cuff impulse and where you get the non-expansile cuff impulse.
Sir, in inguinal hernias, we get an expansile cuff impulse.
Right.
In femoral hernia, we get a non-expansile cuff impulse.
No,
Femoral hernia will always, it will also produce the same.
It's the same. Anything else?
Other than
Not a
hernia.
hernia. It is not a hernia.
something with the ascending from the leg.
Either ascending from up or coming down also, both.
What is the Morrissey?
Very good for varicose vein. If there is the walls are incompetent, then also we can get a cuff impulse.
So in case of varicocele, you can get it, and in case of saphenous varix, you can get it. Okay, in both cases, you will get the non-expansile cuff impulse. Now, in this patient,
Okay.
you know, if there is a umbilical hernia which is occurring in the adult, you have missed the most important examination finding, which is the cause for the umbilical hernia in the adult, which you have not told. Abdomen is mildly distended. What is the commonest cause of umbilical hernia in the adult?
Obesity.
Not the obesity.
Obesity, it will be umbilicus will be puckered. It will go inside.
Patient also had a bleeding from the mouth. Just giving the hint for that. Yeah.
Sir, in liver failure.
Ascites. No? Okay,
Smiling
ascites is
umbilical.
the because of any reason, ascites because of any reason is the cause of umbilical hernia in the adults. And in your examination, you have not mentioned anything about the ascites.
He has straight away gone to the swelling. He has not looked into the other parts of the abdomen.
As said before, the contours have to be mentioned. The peristaltic movements and pulsating swellings and the color of the skin all had to be mentioned.
And fluctuation in general, you have to have checked fluid thrill, signs of free fluid rather than fluctuation.
Yes.
User, in which position you examined your patient?
So first, the patient was examined in a standing position, and then I examined the patient in supine position.
Did you check for the muscle tone?
Yes, sir. Sir, in supine position, with both raising, flexing the leg at knee joint, and without with the extension of the leg at knee joint, both were the patient were examined in both this position.
What is that called as?
What is
Testing for the
Sharon's
muscle tone, what is
triangle?
that called as?
What is Sharon's triangle?
Sharon's regime, which no, what is something related to that? Sharon's
Hyperesthesia movements presence. It's a palpatory examination. Sharon's triangle, classical.
Jijor, I must appreciate your tender, loving hand, because the patient has come with a acute pain at the umbilicus region, but on palpation he has no pain. So you are a very smooth examiner, because you have very categorically said there is no tenderness along the swelling.
Those bulges which occur in the lower abdomen are called the Malgagny's bulge. Okay.
Yeah.
Where do you look for Malgagny bulge? Where do you normally expect a Malgagny bulge to be there? It is intraumbilical, parallel to the inguinal, lateral to the rectus muscle. So that will tell you the abdominal wall is weak. The muscle tone of the muscle is weak. Next slide. What is your percussion on the abdomen? Is there any free fluid?
Sir, if there is fluid, there will be a dull tone.
No, you have only mentioned about the tympanic note on the swelling. What is in the abdomen? Is there any free fluid?
So there will be dullness and shifting dullness there.
You could make it out. There is a fluid or not?
So there was no thrill present.
Your patient presented with a 3 days obstipation, but it is strange to see you are able to make out the bowel sounds. That was your chief complaint. No, that you are not mentioning. Your complaint is 3 days obstipation. Both. What is obstipation? Because the word I saying you use the word obstipation. That means he is not passing the flatus also. But how do you get the bowel sound in that case? So there is some mismatch. The surgical presentation is always 1 plus 1. It's a mathematical. Where you touch one part, another should also correlate with that. Now you are presenting a case that says your bowel sound is normal, but the patient is a 1 day, it is an acute obstruction. You are taking in a case in a very, very severe condition, 3 days old obstipation case. So where do you look for bowel sound? What is the normal bowel sound?
There is Borborgami sounds.
No, Borborgami is not the normal bowel sound. Huh? How do you look for bowel sound and where do you look for bowel sound?
Where do you look? How are they heard? Frequency, character, duration.
So please don't take it lightly because these are a very important findings. The sweetest sound for a surgeon is only the bowel sound. Sweetest music. So you must be very thorough with that. Must be very often, very all cases you should make familiar with looking for the bowel sound. So this is going to decide this patient, whether you are going to take the case for surgery immediately or not. All that is going to depend upon that bowel sound. Okay, go ahead. What is?
Did you go for CT scan straight away?
No, he has done an ultrasound, no? First.
And
we had done a faster. Unfortunately, that report has been misplaced.
Okay.
And we had immediately went for a CT scan as well.
No, but I'm little surprised to see there's a 12 centimeter defect there. How do you get a 12 centimeter defect in the umbilicus and still you have a irreducibility?
It was mentioned in the report, sir.
No, it must be 12 millimeter because 12 centimeter defect, there cannot be an obstruction. There cannot be irreducibility.
It was a millimeter, sir. Just a spell mistake. Sorry.
So please check that whether you are writing is a 12 centimeter. The 12 centimeter is a very huge defect.
And the swelling will be even bigger. The swelling, the irreducible will be even bigger.
It was a 12 mm. It was a 12 mm, 1.2 centimeter defect.
Okay, problem.
It was a 1.2 centimeter defect.
No, again, because in the CT scan also the same thing you are mentioning, 12 into 9 centimeter defect. So, Jujar, you must be careful using whether it is a millimeter or a centimeter.
After the investigation, the patient was diagnosed with an irreducible obstructed ventral hernia.
What do you mean by irreducible obstructed? Why unnecessary adjectives? Do you think both are same? They are different.
You cannot have a reducible obstructed hernia. You cannot have.
So,
and also strangulation. All the three are there.
yes. If it is impending, it has to be strangulated. So, as such, Dr. Jujar, this is not a question of lack of knowledge. It is a question of putting everything what you know into implementation, right? Everybody knows, all PG students at the end of 1-2 years know how to diagnose hernia, how to diagnose complications of hernia. But you must think logically. You must examine, take history, examination, and put all the words scientifically, right? And even again, you have not mentioned site here. You have mentioned unnecessarily adjective words. irreducible obstructed, okay, ventral hernia.
You said there is a discoloration in the skin, no, in the initial part. The skin over the swelling was
Yes, sir.
discolored.
Little brownish distribution.
What could be the cause?
So sir, can we rush a bit? He has to go for an emergency surgery. Can we just rush down a bit, sir? Finish the case with all your due
Please,
permission, sir.
Go ahead, sir. Go ahead.
Thank you, sir. Thank you, sir.
So initially, we managed the patient and secured 2 whiteboard cannulas. And the patient was infused with a electric solution. Rice tube was.
What do you mean by whiteboard cannula?
And 3 ml of BS fluid.
Jujar, what do you mean by whiteboard cannula?
Sir, gauge length. The bore of the cannula.
No, because I am asking this question yesterday in a examination, PG examination. I asked the candidates on the ward round on the size of the cannula. Many of the students are not able to say that answer. Please look into that. What you mean by don't use that. Whatever the color, what cannula you are using. Don't use the undergraduate like whiteboard cannula. You say what is the cannula you use, and each cannula has a specificity of how much fluid it can go. So there is a reason for choosing a particular cannula. So okay, go ahead.
216 gauge cannula were used. Rice tube was inserted. Police catheterization was done, and the patient was planned for exploration. Sir, 1.1 into 1 centimeter defect was found in the rectus abdominis muscle. The small ball along with momentum was adhered in the hernial sac. The ball was densely adhered, and there was a little congestion on the small bowel. The bowel proximal to the sac was dilated, and distally the bowels were collapsed, and momentum was entangled in the hernial sac, and there were little changes in the hernia at that time, in the momentum at that time, for which it was excised. The management was excision of the gangrenous momentum was done, and the little fatty tissue was also there, which was excised. The small ball was free from the adhesions, and the mesh was placed, and the wound was closed with drain placement.
Dr. Jujar, I think
below
just wait a minute, Dr. Jujar. You should have allowed the examiners to ask what management you will do. This is what you have doing a case presentation, that this is what we have done, right? What is to be done, that is to be answered in your PG exams, practical exams. So just rather than putting these words as a presentation, as if we do it in some small gatherings or though, you prepare the history, examination and investigation and diagnosis, allow the examiners to ask what will you do, and you have to answer what is to be done, right? We understand that what is done is correct, what is to be done, but still you are supposed to allow questions to be asked for management rather than this is a presentation. Just a word for case discussion in as far as exam is concerned, right? Carry on, no problem.
So I think he needs to. Sorry for all. He needs to rush to the surgery. I'll finish on his behalf, sir.
No problem. He can finish, and we can go for second case. No problem, sir.
Yeah, just finish it fast with the wrap up in 30 seconds.
Okay. Yes.
The surgery was performed. After surgery, the patient was allowed feeds on post-op day 4, and the drains were removed on post-op day 3 and 5. And the patient was
why do you wait at
and the wound was healthy.
Jijor, why do you waited for 4 days for feeding? What is the logic behind waiting for 4 days?
The bowel sounds were not. Sir, for feeding, the bowel sounds were not coming, and the patient was not passing platters or motion. So we waited for 4 days. It was a little longer, but There were no other
There is,
causes.
you are not
We
handled,
looked for,
you are not done any
hypothetically
resection in the
also.
bowel. You are not done any resection in the bowel. You have just, the bowel was normal, only the momentum was the problem. You have done a surgery. But keeping the patient for 4 days in IV fluid, what are the complications you are expecting?
So after the 48 hours, the patient, the body goes.
Dr. Jujar obviously didn't attend the NSCP last Wednesday, day before. The whole thing was about all this. The ASI NSCP was all about all this. When do you start feeding? When do you put in a rice tube? When do you should attend those classes. They're very good. They're just meant for you all, but most of the PGs don't attend that.
I think, sir, we continued. I think he should. He's supposed to leave for the emergency. His resident has come back. So we'll discuss this case. It's a very beautiful case. I'll summarize in short. Dr. Juja, just seek blessings from all the respected seniors, and especially Dr. Ajay Khanna sir, the HOD of BHU, our guru. And I'll summarize the case in short, sir.
Thank you, sir. Thank you for this opportunity to present this.
So this was a very beautiful case. Actually, this case has patient apparently had no clinical complaints for the last 3 days, and suddenly the patient, all of a sudden, one fine day in the morning, had presented with acute abdomen. She had presented in our OPD as well, and we had advised her, planned her for a surgery, and the patient did not get admitted left. All of a sudden, one fine night, somewhere midnight, she had come up with sudden obstruction. There was no bowel sounds, there was no cough impulse, and the patient was almost getting into shock. Apparently, her CT scan, her USG was done on the OPD basis, and CT scan was also done, and it was only 48 or 72 hours probably old. And then we had done an extra abdomen as well. There was a step ladder pattern, so we had planned for an emergency surgery. And owing, we had found that the bowel, actually the bowel was above the sac. The sac was infected. The transverse colon was beneath the sac. So I had planned for we had done a emergency TAR as well, because there was no ascites, no fluid, nothing. So we had done a posterior component separation technique surgery and anterior component separation technique. We did a TAR, a diamond shape. We had put a mesh, and the patient recovered well. And post-op day, it was not the 4th day. It was after 48 hours we had started her on orals and was discharged on the 5th day.
Should we go to the next case, sir?
Will you prefer the supply mesh for this case? Yes, gone. Jujor has gone. Okay. Okay, sir, we can go for the next case. Can I, sir?
Faculty, more comments or?
I think the student has gone, so that we will go for the next case.
Your audio is less, sir.
I think, sir, I discussed this case with you, Kanagavel, sir.
Sure.
Late night in the early morning, I discussed with you this case that we had done something of this sort.
No problem, sir. The main agenda for this forum will be for more of a teaching thing. Yes. But of course, definitely surgery is also welcome.
He had to rush because I had already.
No problem, sir. I think then no problem. If you had to leave for that emergency, I would request you to leave. We can definitely have one more case presentation at a later point of time. Let us keep you retained in spite of an emergency. If you are on call, I think you should leave. And on behalf of all the faculty, I thank you as well as Dr. Jujal for sharing this evening with us. So we look forward for some other day where you are comfortable to do that.
Definitely.
Thank you very much.
Thank you, sir. Thank you, sir.
Thank you. Faculty, we now move on to Dr. Rahul Dameja. Dr. Rahul Dameja is going to share his presentation on a groin hernia. He is from Lady Hardinge Medical College, and he is from kindly contributed by Professor S.K. Tulu and Dr. Deboshi Sharma. I request the faculty to take over. Thank you very much. Dr. Rahul, are you okay? Can you try sharing your PowerPoint?
Yes, sir, I'm trying to do that. Just a minute.
Good luck to you, Dr. Rahul. All the best.
Thank you, sir. Thank you so much, sir, for giving me this opportunity. Good evening, esteemed faculty. I'm Dr. Rahul Dhameja, a second-year PG resident from Lady Hardinge Medical College, and I'm here to present a presentation on groin hernia. So my patient, a 22-year-old gentleman who was a resident of Delhi, unmarried, and a graduation student, presented to our surgery OPD with a swelling in the groin and scrotum for the last 6 months. My patient was apparently well 6 months ago when he noticed a swelling in his left groin and scrotum. The swelling was insidious in onset, gradually progressing from a small swelling in the groin to the current size, reaching up to the testis in the scrotum. The swelling was increasing on cuffing and straining and reduced on lying down. The swelling is not associated with any pain over the swelling, and the swelling is not associated with any period of irreducibility. The swelling was not associated with any pain abdomen, distension, or non-passage of stools and flatus, and there was no association with any vomitings. The patient did not also give any history of swelling over the right groin. The patient did not have any history of any chronic cough or breathlessness, no history of any smoking. The patient had no history of constipation or straining of stools. He had no history of any urinary complaints, no history of any dysuria, hesitancy, urgency, narrowing of stream, nocturia, or dribbling of urine. He had no history of any acute retention of urine in the past. My patient had no history of any hypertension, diabetes mellitus, chronic obstructive pulmonary disease, bronchial asthma, thyroid disease, tuberculosis, epilepsy, or any other medical comorbidity. He had no history of any previous surgeries, blood transfusions, or hospitalizations. He had no history of any treatment taken for the swelling over the groin and the scrotum. The patient also did not have any, the patient consumes non-vegetarian diet which was non-vegetarian high fiber diet with normal appetite. His bowel and bladder habits were normal. His sleep patterns and diurnal cycles were normal. There was no history of any drug allergies, addictions, or habituations, and there was no significant family history. Summarizing my case is a 22-year-old gentleman who's a non-smoker who presented to us with complaints of a reducible swelling over the groin and scrotum since last 6 months, which was not associated with any pain over the swelling. The patient had no significant medical comorbidities or surgical history. Coming to examination,
What do you mean by groin?
Groin is the inguinoscrotal region, sir.
Scrotal region. Because you are repeatedly using the word groin. What are the features includes groin?
Groin is the it's a layman term used for the area which is area in the inguinal region, in the inguinal near the inguinal fold.
Is it only inguinal region? So groin is
Inguinal region involving the right iliac fossa as well.
No, right iliac fossa is not included. When you are juxtaposing your thigh with the abdomen, the areas which are juxtaposing comes under the groin. This includes the femoral region and the inguinal region. The scrotum will not come into the groin region. So
yes, sir. Yes, sir.
Complaints, it is better. But when you come to the present illness or when you are explaining, you must very specifically say whether it is an inguinal region or you are going to have the swelling in the femoral region or it is an inguinoscrotal swelling. It is important that you specify that region. It's a chief complaints, fine, you say the groin. Because the summary also you are using the same word. If you can maybe a little more specific, it will be nice.
Okay, sir.
Repeatedly you was using the word non-smoker. What do you mean? Why do you want very particular about that?
So smoking is a predisposing factor for hernias. For smoking, first of all, smoking predisposes smokers are associated with chronic obstructive airway disease, emphysematous changes in the lungs, as well as a chronic cough, which is a predisposing factor for increased intra-abdominal pressure and hernias. Second of all, the smoking predisposes the patient for a faulty collagen formation due to
the skin.
Type 3 collagen.
Only type 3.
Type 3 is the predominant collagen. Otherwise, elastic fibers, including type 4 and type 1, are also present. Type 3 is not
the predominant in skin. Type 3 is immature. Type 1 is the predominant. You have 80% is a type 1 and type 3. The smoking increases the type 3, reduces the type 1. So you have
the ratio changes.
The ratio is going to be changed.
The ratio is changed.
Metastatic emphysema of reed. Have you heard the term?
Sorry, sir.
Metastatic emphysema of reed. So it is even
sorry, sir.
It is not that cough, intra-abdominal pressure increase, but the deficiency of the antitrypsin and elastase enzymes. So that is same.
Yes,
the same mechanism what you have the COPD, and the same mechanism is where there's a collagen weakness. There's a studies has proved that the collagen is weakened in all those people. So more than the cough,
yes, sir.
It is only the collagen which is more important. So you must be careful because smoking is one of the very, very detrimental for the development of the hernia.
Yes, sir.
Okay, Rahul, what's the diagnosis then? Do you have your diagnosis?
My diagnosis is a left-sided inguinal hernia, which is reducible, uncomplicated, and incomplete.
It reaches to the scrotum, does it?
It reaches till the scrotum, but the testis is seen separately. The patient specifically says that it comes.
Obviously, the testes will be seen separately. Why should a hernia incorporate the testes? So it's a complete hernia, isn't it?
Yes, sir. Yes, sir.
Yeah, so why do you think this person, a young 22-year-old male who's non-smoker, gets hernia? Why do you think he's got a hernia?
Sir, the patient might have the patient may have an indirect hernia due to the presence of the patent processus vaginalis, which predisposes the a young.
So why don't you call it a
male.
congenital hernia? Then why don't you call it a congenital hernia? The processus vaginalis was there right from birth. It won't happen now.
Yes, sir.
Why don't you call it a congenital hernia?
Congenital hernias are early in presentation in the early
Right.
phase of life.
So congenital hernia would be seen
And
at
a
birth.
young male.
At
Yes,
birth.
sir.
At
birth. Yes.
So
sir.
what is Hamilton-Russell's saccular theory of hernia? Have you heard of this?
Sorry, sir, I haven't heard of this.
Hamilton-Russell's saccular theory. So this says that all indirect hernias have a patent processus vaginalis, which opens up because of any reason, and during the life. Okay.
Yes. Sir.
I think that what is the precipitating cause here, that why this patient had a hernia at the age of 22 years?
So there was no precipitating cause for this patient. The patient had no significant family history and no exacerbating factor which would have led to this hernia. There was no history of any heavy weight lifting, no chronic
Okay, Rahul, hang
constipation.
on. Rahul, does weightlifting induce inguinal hernia?
No, sir.
Why do you
It's
say
a
heavy weightlifting?
You want to ask the weightlifting?
sudden weightlifting and with an
weightlifting has got nothing to do with hernia.
Yes, sir,
Otherwise,
yes.
all these weightlifters would be having hernias. Those sportsmen, do they have hernias? They don't.
Yes, sir.
So it's basically weakness of that region.
Yes, sir. There is. Yes, sir.
Not because of weightlifting.
Yes, sir.
Especially for a direct hernia that you talk about. That if indirect hernia, it is mainly because of the Hamilton's theory with the persistence of the process vaginalis. How do you differentiate congenital hernia from heterocele? What is congenital hernia? Heterocele.
A congenital hernia will.
What is the difference between hernia and heterocele?
First of all, a congenital hernia will be an inguinoscrotal swelling, not a predominantly scrotal swelling.
No necessary, not necessary for that. Even ancestral heterocele can be a congenital heterocele.
Not necessary.
What is the difference between congenital heterocele and congenital hernia? Both has the same mechanism of the process vaginalis.
Yes, sir. The congenital hernia will have omentum or the bowel as content.
Depends upon the content. If you have the content is the part of the viscous, then you call it as a hernia. If it's probably the fluid, you call it as a hernia. So treatment, everything is almost same for congenital heterocele and congenital hernia.
So Rahul, what do you think is the content of your hernia? You've not mentioned anything about in your diagnosis about content.
So content is probably omentum, which is usually the most common content in the indirect sacs. But the patient does not have any history of any bowel complaints, any alteration of the bowel habits. Therefore, my first differential would be an omentum as the content.
Look, in your history, you cannot come to this diagnosis.
We cannot.
That's why I asked.
Yes, sir.
Yes, so you should say I cannot. Right. So that's why I wanted this answer. That I cannot distinguish on history.
Definitely, we cannot.
Unless you ask him whether it reduces with a gurgle or not. If he says it reduces with a gurgle, then you maybe you can. But by history, you cannot. Okay. So it should be more forthright.
You are using a lot of terminologies like there is no dysuria, hesitancy, urgency. Can you specify what is hesitancy? What is urgency?
Urgency is the patient feels an urgent need to void the urine and hesitancy means when he goes to the
what is the difference between frequency and urgency?
Increased frequency is passage of multiple increasing in the frequency of urination per day, whereas urgency means the patient will feel an urgent need to void the urine without any increase in the frequency.
No, it's not like that.
What did you ask for this patient?
Feels the need to pass, but he will not be
in a 22-year-old male
up to the toilet. He will pass urine before that he is reaching the toilet. That is an urgency which you are going to talk. And why do you talk about narrowing of the stream?
So these are basically lower urinary tract symptoms, which are
How do you differentiate the narrowing of the stream due to prostate or due to stricture urethra? What history? Patient says, I have a difficulty in urine, narrowing of the stream. Can you say by the history whether it is a stricture or whether it is a prostate? You need to ask the patient how he is passing urine. If he is using a pressure or the compression to pass urine, it could be more in favor of a prostatic enlargement. If he is standing there and strain without straining, if he is pressing a dribbling of urine, it is more in favor of the stricture.
stricture.
So you are unnecessarily putting all the terms here. History of urinary, you are talking about this. You would never ask this, nocturia. If the examiner asks the patient whether you pass urine more in the night, patient will say yes. So please don't unnecessarily put in all the terms, dribbling of the urine. Why do you ask that history, dribbling of the urine? What kind of dribbling you are going to expect in a 22-year-old individual?
Rahul, may I come in? Rahul, look, in a 22-year-old male, I will think of stricture urethra rather than a prostate.
Yes, sir.
Right. So this whole history of taking is for BPH rather than for stricture. Right? This needs to be modified.
Okay, sir.
Why did you ask about the thyroid disease in your patient? You said no history of thyroid disease.
Sir, to rule out any medical comorbidities. For preparing the patient for OT, as and when the patient is going to be planned for an operative procedure, we need to take
his drug history. Did you take his drug history?
Yes, sir. There was no history of any drug allergy. No drug allergies, and the
Allergy,
patient
no.
was not any kind of.
Right.
The
So you
patient
just
was
find
no
out.
no. There was no history of any treatment taken or no history of any drug intake.
Ask for the thyroid abnormality of the patient. If I am asking the Rahul, do you have any thyroid abnormality?
How will you know? You can't.
No, please don't
Yes,
look at the history. That if you find out there is a back bradycardia, if you have the tachycardia, if you have associated features, then you can relate to that. You cannot in a 20-year-old individual asking for if you have a thyroid problem. That cannot be put like a blanket question to the individual.
You just ask whether he's taking any drugs for thyroid or for blood pressure or for diabetes. That's the way. You can't just say, "Aapko sugar hai kya?" like that. You can't. Okay.
Okay, sir.
What surgical history you were interested?
Surgical history is like any previous surgeries in the inguinoscrotal region, any previous pelvic surgeries if the patient has undergone any, and any previous history of appendectomy. If it's there, it predisposes the patient for a right-sided inguinal hernia, which is not applicable in this case, but in general for inguinal
Do you
hernias.
expect appendectomy with hernia?
So during appendectomy, there is an inadvertent severation or any injury to the iliohypogastric nerve,
Are you
which
going
leads
muscle cutting or muscle splitting?
a muscle splitting.
So do you
A
think the muscle splitting you are going to injure the what?
muscle cutting
Nobody does
procedure.
muscle cutting nowadays. I don't think any surgeon in the last 25 years will do the muscle cutting for appendicectomy.
Yes, sir.
So what nerve you are expecting to injure?
So ilioinguinal and iliohypogastric
The
nerves.
muscle in the appendicular surgery. Where will be the nerve? When you are doing surgery, where will be the nerve?
Iliohypogastric. Iliohypogastric.
No, not. We are not talking about iliohypogastric. Now, ilioinguinal, you said you will injure in appendicectomy. Where is the ilioinguinal nerve when you are doing appendicectomy? What is the plane of the nerve? It is between the transverse abdominis and internal oblique. When it comes to the ilioinguinal canal, it comes superficial to that. So, by cutting the ilioinguinal nerve, what you are going to do? What is the damage it will create? It's very, very rare nowadays.
Make the
why you produce hernia?
It will make the lower part.
See, all the intra-abdominal muscles are supplied by the all the muscles.
Just say.
It's a intercostal nerve, all the intercostal nerves are supplying. So what type of hernia you are expecting? Very rarely, if you are injuring the ilioinguinal nerve, so very rarely you can see the conjoined tendon part that is maybe supplied by this. That weakness may be happening with the developer Hasselbalch hernia. All these are very, very unusual. So please, in nowadays, don't use appendicectomy as a reason. More than appendicectomy, even if you can put a drain, when you are putting a trocar drain or some you put a drain,
Yes,
that
sir.
can injure the more inguinal nerve, ilioinguinal nerve than the appendicectomy.
Okay, sir.
Or in which type of the appendicectomy or the appendix disease, you will do the muscle cutting rather than muscle splitting? In which condition of the appendix, you would prefer to do a muscle cutting? Okay, if you are draining appendicular abscess, if you are draining an appendicular abscess, then in that case you make a muscle cutting incision rather than muscle splitting. Normally you never cut the muscle, but if it is
Yes, sir.
appendicular abscess is there, then in that case you carry out the muscle cutting.
Okay, sir.
Can you tell what are the various collagen disorder which can lead to hernia? Name of some.
Sir, congenital disorders such as Marfan syndrome.
Yes.
Uh,
Any other syndrome? The patient has the aortic aneurysm. What about the Ehlers-Danlos syndrome?
Ehlers-Danlos, yes, sir.
There you can have also the hernia.
Yes.
We'll go in the examination.
So by a young adult, when you are presenting a 22-year-old adult, don't make the presentation very complicated for asking for everything on the ground. Because here, how will you rule out it is not a sports hernia? What is sports hernia?
Sports hernia is herniation of the preperitoneal fat into the uh, posterior rectus sheath in the lower in the midway between the umbilicus and the.
For the people who are very active in the sports, especially players, there is when the deep inguinal ring is ruptured, the fossa ovalis is ruptured, you can get a hernia within the sac. It is be within the just out of the deep inguinal ring. So there they can present as the inguinal hernia. So if at all, if you can only bring the history whether the patient is a very, very high sportsman, that's the one expectation we'll think. We don't put in all these such bronchiectasis to all the comorbidities just for the sake of history taking. Specify to what is the need, what is the patient, and what you are going to ask. Go ahead with the exam.
Okay. So my patient was examined in a well-lit room with informed consent and adequate exposure. The patient was examined in a standing position and in the supine position. My patient was conscious and oriented to time, place, and person. General condition was fair. Hydration seemed to be adequate, and the patient was afebrile. The patient was average built with a BMI of 22, with no signs of any nutritional deficiency. His BP was 112 by 70 millimeters of mercury, measured in the right brachial artery in the supine position. His pulse rate was 68 beats per minute, measured in the right radial artery, which was normovolumic. His SpO2 was 98% at room air, and his respiratory rate was 16 per minute, which was thoracoabdominal. The patient had no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. There was no visible neck swelling, and the JVP was also not raised.
So you look for JVP in a 22-year-old individual. What prompted you to look for JVP here?
Sir, it's a part of the general physical examination to evaluate the neck region of the patient for any chronic signs of any chronic heart failure.
When your history is suspecting your chronic heart failure, then you
yes, sir.
Send for JVP examination.
Okay,
an adult when all other things are ruled out, and don't spend your time unnecessarily for looking into JVP. What are the components of JVP? What are the waves you look for?
Sorry, sir. Can you
What are the
repeat the
waves
question,
you
please?
look in the JVP?
Sir, internal jugular vein.
What are the things
External
what do you look for JVP?
Sir, on the right side of the neck and at a 45-degree angle, the external jugular vein is visible.
That is normal. Any individual, you will have external jugular vein will be visible.
Yes, sir.
That is not JVP. So you learn what are the waves you get in the JVP and what it signifies and why you are looking for it. No, otherwise, please do not add in a very well individual adult individual. Don't put this examination like that femoroarterial, femorobrachial delay, radiofemoral delay. All this in the general examination, the general surgery, we are not expecting that unless it is very specific to that particular case.
Okay, sir.
Go ahead.
Sir, on inspection of the inguinal-scrotal region, there was a pyriform swelling of around 5 into 4 centimeters was seen in the left inguinal-scrotal region, extending up to the inguinal region above and below up to the bottom of the scrotum. The skin over the swelling showed no discoloration or engorged veins or any scar marks. There was cuff impulse present. There was no visible peristalsis over the swelling, and the testis was seen separately from the swelling. And the position of penis was also normal with no deviation. On palpation, the temperature over the swelling was normal with no associated tenderness. It was not possible to get above the swelling. The swelling was inguinoscrotal in nature with a pyriform shape, 5 into 4 centimeters, with smooth surface and regular margins and doughy consistency. The swelling extended from the superficial inguinal ring above to up to the upper pole of testis, with testis palpable separately. The swelling was reducible on lying down with minimal manipulation by the patient, and the deep ring occlusion test was done on the left side, which was positive. The swelling on percussion was dull. A dull note was heard on percussion. On auscultation, there were no bowel sounds heard over the swelling. The right inguinoscrotal region showed no swelling or cuff impulse on inspection and palpation. The right testis was normal in size. On per abdomen examination, the abdomen was normal in shape. All quadrants moved equally with respiration. The umbilicus was central and inverted. There were no scar marks, no visible veins, pulsations, or peristalsis. No Malgagny bulge was noted on leg raising test. On palpation, the abdomen was soft, non-tender, no guarding or rigidity was seen. There was no mass, no palpable mass, and no organomegaly. There was no free fluid on percussion. On auscultation, normal bowel sounds were heard. On digital rectal examination there were no external findings, no external hemorrhoids or no fissures or fistulas. The inner tone was normal. The lumen was collapsed with no growth, and the mucosa was normal. The finger was fecal stained. Respiratory system, bilateral air entry was present, which was equal. Bilateral vesicular breath sounds were heard. Normal heart sounds were heard with no added murmurs and no added heart sounds. On CNS examination, the patient was conscious and oriented, all motor and sensory functions intact, with no signs of any focal neurological deficit. Summarizing my case, my patient is a 22-year-old gentleman with a left-sided indirect inguinal hernia, which is reducible, incomplete, uncomplicated, with omentum as its content, with no significant medical comorbidities or previous surgical history.
You have not done any special test for the hernia?
Sorry, sir. I didn't.
You have not carried out any special test for the hernia?
Sir, I did a deep ring occlusion test for the hernia, which was positive in this patient.
What does that mean? What does that mean?
So that means the hernia was indirect in nature. a deep ring occlusion test is positive in an indirect hernia, whereas negative in a direct hernia.
What is the fallacy of this test?
So the fallacy of this test is usually seen in patients with large patulous deep rings, where our thumb is unable to completely occlude the hernia, completely occlude the deep ring. Second of all, this test is false negative in cases of a pantaloons hernia, where both direct and indirect hernia are present.
What is a deep ring?
Deep ring is the defect in the internal oblique and the transversus abdominis muscle. It is surface.
Defect in the muscle.
Sorry.
Is it a
defect in the muscle?
Do you think deep inguinal
yes,
is a defect in the inguinal oblique muscle?
So the inguinal, the fibers of the muscles arch over the deep ring.
That is a conjoined. What is the deep inguinal ring? Where is it?
It is located 1.25 centimeters above the mid-inguinal point. It is the defect in the fascia transversalis.
No, please, again, refer what Das will say, but Bailey and Lowe and the recent studies will place it is not the mid-inguinal point, it's the midpoint of the inguinal ligament.
Yes, sir.
That's why we always say it is you palpate the femoral artery and go above 1.5 centimeter above the femoral artery, you will feel that. So,
yes,
you must say what is deep inguinal ring? It is a defect in where?
In the fascia transversalis.
Okay. Then why do you want to put the internal oblique muscle? What are the derivatives of fascia transversalis? What are the structures developed from the fascia transversalis? What is bundlet of Thompson? What is pectineal ligament? Fossa ovalis. So you must study the laparoscopic anatomy of the inguinal region also, so that you will know what are the space created by the transversalis fascia, what are the structures derived from the. And your swelling is 5 into 4 centimeter, but pyriform shape. What do you mean by
yes, sir.
shape?
The swelling is constricted in the upper region, in the inguinal region, whereas it becomes enlarged when it comes down to the scrotum. It forms a pyriform shape.
Oh, yes, the top upper limit is 5 centimeter, lower limit is 4 centimeter. Can it looks like just because it is indirect hernia, don't bring in pyriform shape. If you are sure that
okay,
and I'm little doubtful when you say inguinal scrotal swelling, it is only 5 into 4 centimeter. It's a very small swelling. To call it as inguinal scrotal swelling. So we must be properly measuring it and put that appropriate shape.
Okay, sir.
You said that it is going up to the bottom of the scrotum on your inspection, and then you are saying that you are able to see the testis separately. Does these two things?
No, sir.
Just see here.
The swelling was seen in the upper part of the scrotum only. It was the testis was inspected. The testis was seen separately from the swelling, but the swelling was reaching up till the upper pole.
You are written below up to
Rahul,
the
you can palpate the testes if after reducing the hernia. That's what it means. You palpate the testes separately once the hernia is reduced. That's it.
No, on your inspection you have written and below up to the bottom of the scrotum. Is it? The bottom is the lower part, is it?
Yeah, 5 centimeters.
This is till the upper pole of testis.
5 centimeter swelling will not go up to that.
Up to the bottom.
Yes, sir. Till the upper pole of the testis only.
It is up to upper. So when you say it is incomplete variety, what is that incomplete variety? What is the name of this type of hernia?
This type of hernia is known as a funicular type of hernia, where the hernia reaches up till the upper pole of the testis. Whereas an incomplete hernia is basically an hernia which does not reach up to the base or the bottom of the scrotum.
What is the other incomplete hernia?
Other incomplete hernia is a bubonocy. there is a bubonocele which stays in the inguinal canal only and does not cross the superficial inguinal ring.
Okay. What is the infantile hydrocele? We have a congenital hydrocele.
Yes, sir.
What is infantile hydrocele?
The peculiar.
So accumulation of fluid in the tunica vaginalis due to the presence of processus vaginalis, patent processes.
What is the
That is
peculiar?
the vaginal hydrocele.
Yes, sir.
I'm asking about the infantile hydrocele.
You talked about the getting about the swelling. What is the specialty?
Yes, sir.
Infantile hydrocele.
We are unable to get above the swelling in a case of infantile hydrocele. It is present.
Okay, so where is the blockage? You know, in the case of the congenital hydrocele, that is patent. But in the infantile hydrocele, there is a block is there. Block at the level of the deep ring. Okay, that is why you are not able to reach above
Yes.
the. So it is up to the. So that is the infantile hydrocele.
Rahul, you have put us a
Okay.
no engaged veins and no discoloration. What do you look for? A discoloration and engaged vein?
So in any cases of strangulation, if there is present, there is skin discoloration, the skin appears red, or in any cases of inflamed hernia, the skin might appear red over the swelling. In cases of presence of varicocele or
You will visible the engaged veins.
the engorged veins will be palpable.
You have put this in the inspection finding. What is an isolated engaged veins you can see in that region, inguinal region? The superficial epigastric vein can go for an isolated varicosity. You can see the like that saphana varix, like that varicosities can be seen in isolated.
Yes.
Not a typical of any
But
hernia hydrocele to produce an isolated.
that is usually seen in the post-operative period as a complication of hernia, where we inadvertently damage the superficial inguinal vein, superficial epigastric vein.
Your patient need a minimal manipulation. What is the manipulation he needed for a reduction?
For the reduction, yes.
For what? What manipulation he does?
He used his, the swelling did not go completely on lying down. The patient used his hands to manipulate the swelling and then reduce the swelling.
What is the position you adopt for the increasing the chance?
What is the position of the hip joint?
Usually it's better to reduce the swelling when the hip joint is flexed with a slight adduction.
Where do you want to adduct?
So to decrease the pressure to decrease the stretch over the external oblique muscles, over the abdominal muscles.
What are the adductors of the muscle? This is adductor longus. It has nothing to do with external oblique aponeurosis. So where is that adductor is attached, inserted?
Adductor longus is attached to the pubic tubercle.
So what is the relation of pubic tubercle? So it is the superficial inguinal ring is attached to that.
Attached to it, yes.
It's produced on that, the door of the opening. So you want the door
yes,
to get relaxed. If you are putting a tension on the adductor, the door is get tensed. So that is why you are the adduction of that.
What is this maneuver called as? What is the name of this maneuver?
I don't know the name.
Flexion, adduction, that maneuver.
This is called the Texas.
Yes, sir. Taxis.
Okay. Why we are not now recommending taxis?
So taxis is usually any forceful taxis is not recommended to avoid any inadvertent.
All will do the forcible. You can't do the much force.
Because it increases if any part of the bowel or the omentum is strangulated, it would inadvertently increase the chances of it going back into the peritoneal cavity.
In block reduction, you can miss the possibility of the strangulation which has happened.
Yes.
Possible, we can't do that.
Yes.
How do you differentiate between enterocele and the omentocele?
Sir, enterocele and omentocele can be differentiated on the basis of examination. On inspection, there will be visible peristalsis over the enterocele, which will be absent in a case of an omentocele. On palpation, the omentocele usually appears doughy in consistency, whereas an enterocele is usually elastic. And there might be associated gurgling in the enterocele on palpation. As well as on palpation during taxis, the first part of the enterocele goes in easily. The first part of omentocele goes in very easily, whereas there is difficulty in reducing the distal part or the later part of the contents. Whereas in an enterocele, the first part, there is difficulty in reducing the first part of the hernial contents, whereas the later parts go in very easily. On percussion, an enterocele will show a tympanic note on percussion, whereas an omentocele will show a dull note on percussion. And on auscultation, there might be bowel sounds heard over an enterocele, which will be absent in an omentocele.
What is a sliding hernia?
A sliding hernia is a hernia where a part of the bowel or any other organ, any hollow viscus, a part of it comes sliding into the hernial sac, causing part of it comes into a part of the circumference of the hollow viscus comes into the hernial sac.
That will come inside the cavity, in the hernial cavity?
Yes, sir, in the hernial cavity.
And that will be not a sliding hernia if it is coming inside the cavity, that part. It will form a wall of the hernia sac, isn't it? Okay, one wall will form. And how do you clinically diagnose that probably it may be a sliding hernia? Okay, hernia which is very large and it is not reducible, partially reducible or not reducible. So large hernia which is not reducible or partially reducible may be suggestive of a sliding hernia.
Okay.
What is incarcerated hernia?
Incarcerated hernia was previously described for a colon, a part of the colon with hard stools, which was impacted in the left-sided hernia. But nowadays it is used the word is used synonymously with a case of obstructed hernia.
But still you can differentiate incarcerated hernia from obstructed hernia.
Yes, sir. Incarcerated hernia was described for a sigmoid colon or a part of the colon which with presence of hard fecal matter which gets obstructed in
indentation will be positive, and there will not be any other features of obstruction may not be there.
Okay.
How did you measure the temperature of the swelling? Scrotum?
So temperature was measured by the back or the dorsum of the fingers with comparing it with the abdominal temperature.
So first
normal body temperature of the patient.
First, where did you kept your fan?
Sorry, sir. I didn't
First,
get
you
your
looked
question.
at the abdomen or at the scrotum?
First over the scrotum and then over the abdomen.
No, it is the reverse is true. You should feel the normal temperature of the individual. Then only you should compare.
Okay.
The fan should be accumulated to the normal temperature. But these are the minimum things what we are
Okay,
now
sir.
seeing that
Sorry.
in the examination you are making the mistakes. Straight away you are going to put the hand on the scrotum. So always feel the normal temperature, get acclimatized to that. Then you do for the local examination of that. You have not talked about anything about the scrotum. Because you said there is a swelling up to the deep bottom. What is the rugosity has happened? Does any other change there?
So the skin over the scrotum was normal.
No,
there was no
about
change.
your dilated veins. Does that you can talk about the rugosity or any other changes you can see about that.
Okay, sir.
Siemens technique test you have not done. Why intentionally
No,
you
sir.
have not done?
Siemens test is now obsolete, sir.
No one says it is obsolete.
Usually not performed in the
So
clinical
every test is
examination.
obsolete. If you say deep ring occlusion test is also then obsolete. You can do ultrasound and make it. Postgraduate at least know the Siemens test. Ring occlusion
Yes, sir.
imagination test, yes, it is agreed. You are not doing.
Okay, sir.
But try
Okay,
to
sir.
do Siemens test because though it is not very confirmatory to go into the diagnosis, but
Yes, sir.
you should mention in your case sheet Siemens test.
Okay,
Ring
sir.
imagination test, yes, you will be relieved because it is Western literature is not supporting that.
Okay, sir.
So what is your final diagnosis?
So my final diagnosis is a 22-year-old male with a left-sided indirect inguinal hernia, which is reducible, incomplete, uncomplicated, with omentum as its contents.
So how will you proceed?
Sir, I will first proceed with the basic investigations, the PAC investigations of this patient. I'll get a CBC, biochemical LFT, KFT, and serum electrolytes for this patient, a chest X-ray, INR, and ECG for this patient. I'll do a routine workup, and I'll post this patient for an elective surgery on an open mesh, an open Lichtenstein tension-free mesh
Grade your
herniaplasty.
hernia? You want to grade your
Sorry.
hernia? The staging for your hernia?
Sir, according to the NIHUS classification, my patient's hernia is a grade 2 hernia, an indirect hernia with no.
You made it clinically?
Sir, a small indirect hernia comes under NIHUS class 2, whereas
No, it is on the size of your deep inguinal ring.
sir, it is slightly bigger than the size of the deep inguinal ring, but if it does not cause any distortion of the anatomy and does not cause any displacement of the superficial epigastric vessels, then it might not.
European classification?
European classification classifies the hernia into 3 parts: indirect, direct, and femoral hernias. And it classifies the hernias on the basis of the size of the defect, class 1, 2, and 3, where the size is the size is 1.5 to 3 centimeters. Then it's class 1, less than 1.5 centimeters is class 1, 1.5 to 3 centimeters.
1.5 centimeter size.
Usually it's not seen.
You can your finger size. So each one finger is related to 1.5 centimeter size. If you have
Yes,
a 2-finger defect, 3. So ideally, so you are doing ultrasound. If you are doing that, you can make it very firmly. Otherwise, when clinically also you can make using the finger size the defect, and then you can make the chart. You should make it as a habit to make the chart of the hernia when you are making either one of the classification, either you are Gilbert, NIGUS, or European system of the classification.
European Society.
If it's not routinely you start using that, and it will become easier for you to go ahead.
Yes.
Any investigation you do?
Sir, ultrasound can aid the diagnosis of a hernia, but is not usually not used in the diagnosis.
But what are the indications of carrying out the ultrasound in a case of inguinal hernia?
So any hernia which is associated with any mass palpable in the abdomen, or if there is any associated change in the size of the testis or the swell.
One in the pediatric age group, okay? In the pediatric age group, because you are not very sure about whether the child has got a hernia or not. That is one indication. Second is you can find out how much is the defect in the posterior wall is there. Okay. And then in the case of the sports hernia, where you are thinking about that, but you are not able to find anything there. So So these are the few indications of carrying out the ultrasound in the case of the inguinal hernia. When you will do the CT scan, when you will do a CT scan in inguinal hernia, especially in the obese patients. Okay, the patient is obese patient and you are not sure about whether the patient is complaining or there is some pain is there, but not sure whether some bulge is coming out or not. So especially in the obese patient, the CT scan is one of the investigations to find out does the patient has got a hernia or not. What is herniography? Have you heard about herniography? Though it is not done nowadays.
Herniography is basically tissue repair where we
Herniography, not
sorry, sir.
herniography. Herniography.
Herniography.
So
Herniography is installation of contrast in the peritoneal cavity and then then obtaining radiographic images where the hernial sac is then the contents of the hernial sac are then radio opaque in nature, and we obtain images pertaining to it. Usually,
no more done. It is no more done.
Yes, sir. It's obsolete.
Thing of the past.
What is the indication for
Yes.
it? Can you remember any indication? Where was it done before? It's actually called peritoneography. And why was it done before? Why? What was the indication for it? In children, to detect an incipient hernia on the other side. If the child, in how much percentage is does hernia on the other side occur? If there's a hernia on one side, what's the percentage in children? Do you have an idea?
Yeah. No, sorry.
About 20%. So they used to do peritoneography and still die, and then check for an incipient hernia on the other side. Right? That was it.
Okay, sir.
You made a diagnosis, you have done an ultrasound, and you want to do a surgery.
Yes, sir.
What are the contents of that spermatic cord?
Contents of the spermatic cord are firstly, sir, the vas deferens.
Can you trace the vas deferens, where it's originate, where it ends?
So the vas deferens arises from the testis, from the epididymis of the testis, and then goes into the spermatic cord, then travels into the deep ring, and then joins the prostatic urethra.
Anything else is joining with that? Is it directly joining, or is it along with something else?
Along with
Joins with the seminal vesicles.
Seminal vesicles, yes.
So, testicular artery, where it starts, where it ends?
Testicular artery is a branch from, on the left side, it's a branch from the left renal artery, whereas on the right side, it's a side branch.
Artery.
No, this is a very common question where you are making mistakes, PGs. Testicular artery is a branch from where? Though it looks like undergraduate question, but the postgraduate anatomy, that if you are not concentrating, you will get into trap. On both the side, it is only from the aorta. It is not from the one side. It is only for the vein you have a differential. What are the other arteries in the spermatic cord?
Cremasteric artery and cremasteric vessels.
It's a branch
of internal ilia. Cremasteric artery is a branch of superficial epigastric.
Superficial epigastric. So you read whatever the contents anatomy, where it starts, where it ends. Cremasteric artery, where it ends. What is the role of inferior epigastric artery? And inferior epigastric artery comes from where? And what is the all the artery to the vas? So in an anatomy is more important in a hernia surgery. Either your
Yes.
discussion will be more towards an anatomy or more towards the surgical principles. So each you must know whatever the contents, whether it's a nerve, all the three nerves, where it starts, where it ends. Similarly, the pampiniform plexus or the vein, where it goes, where it starts, where it ends, lymphatics, vas, arteries, all the arteries you must know. So it is
Okay, sir.
go today itself and read the anatomy of the inguinal region. It is a very important role it will play in the examination. So what do you want to do for this
Okay,
case?
sir. Sir, I want to do a mesh plasty for this patient, either
You
by
don't
an
have
anterior.
option? You want to decide and you don't have an option for that?
No, sir. I have multiple.
So you will discuss with the patient and then you take a decision.
Yes.
So what are the options you have?
My options are herniorrhaphy and a repair with, which is a repair without.
What logic you are proposing herniorrhaphy? Today the universal consensus is only hernioplasty.
Hernioplasty, yes.
So herniorrhaphy is not an accepted on a consensus, universal consensus. You can do still.
Yes, sir.
So you
Yes,
cannot
sir.
have that put as a herniorrhaphy as a first choice to the patient.
Yes. The first choice would be hernioplasty, where we can give the two options. We give options as an open anterior approach or a laparoscopic approach.
Okay, this child is 22 years. If this child would have been 12 years, then what was your choice? Okay, child of 5 years coming to you with a hernia, a child of 12 years coming to you with a hernia, and child of a boy of 22 years coming to your hernia. What are the various choices?
Sir, in children, a herniatomy would suffice, whereas in cases of a congenital hernia, whereas in adults, usually hernioplasty is preferred.
12 years child?
Hernioplasty would be indicated.
Hernioplasty is usually after 16 years. Okay. Usually after 16 years. So if it is 5 years, herniatomy. If it is 12 years, herniorrhaphy. And if it is 16 years or 22 years, then the hernioplasty. Okay.
Okay, sir.
So when you're doing the open hernioplasty, what are the various nerves you are going to encounter?
So we're going to encounter the iliohypogastric nerve, the ilioinguinal nerve, and the genital branch of genitofemoral nerve.
Where do you find the ilioinguinal nerve?
Ilioinguinal nerve is 2 to 3 centimeters above the anterior superior iliac spine, and it encompasses, it courses.
You are not talking about anterior superior iliac spine. You are opening the hernia.
You are operating the patient.
Spine, no? When you are doing a surgery, where do you look for the ilioinguinal nerve?
Okay, sir. So it runs parallel to the inguinal canal, the ilioinguinal nerve.
It comes in the canal.
Runs above the canal.
No, is it coming through the deep inguinal ring?
Not a part of the canal.
What is the place where you can
genital branch of the genital branch of genitofemoral nerve comes is a content of the spermatic cord which comes out from the deep inguinal ring.
Okay.
What is the place where you are most likely to damage the ilioinguinal nerve? When you're opening the superficial ring, when you're opening a superficial ring, That is the place where you are most likely to damage the ilioinguinal nerve.
Okay, sir.
Okay, genital branch of the genitofemoral will be in the spermatic cord on the posterior
The
side.
cord itself. Yes, sir.
Posterior side. And iliohypogastric nerve, where it will be?
It runs
Where you can damage that,
superior.
yeah.
Sorry, sir.
When do you get a iliohypogastric nerve?
It runs superiorly to the ilioinguinal nerve in the above the conjoint tendon.
So
Near
where
the
you can
conjoint.
damage, where you can damage that?
While creating the space for the mesh placement.
Creating the
While
space
doing
when you are suturing the superior part of your mesh.
The mesh, yes, sir, over the conjoint tendon.
There you can damage.
The option is Cns slide. When you are making a Cns slide cut, when you make in the to relax the abdomen when you are doing the hernia raphe, so that also can produce that. Normally by the mesh fixation, it will be we must be careful on the superior aspect.
Yes.
And what are the nerves you encounter during the laparoscopic repair?
Sir, during the laparoscopic repair, the genital branch of genitofemoral nerve and the femoral branch of genitofemoral nerve. On the lateral aspect, we also encounter the lateral cutaneous nerve, lateral femoral cutaneous nerve, and lateral cutaneous nerve of thigh, and this.
Which is the third nerve. 3 nerves in the lap, 3 nerves in the open. Okay, the femoral branch of the genitofemoral nerve.
No, yes.
Lateral cutaneous
Genital
nerve.
branch.
No,
And
not
the
the
genital branch.
Genital branch comes in the open repair. Okay, usually
Okay,
comes
sir.
in the open repair. So, femoral branch of the genitofemoral nerve, the lateral cutaneous nerve of thigh, and the femoral nerve itself.
Yes.
So these are 3 nerves. You can sometimes have the genital branch also, but mainly it's the femoral branch of the genitofemoral, femoral nerve, and the lateral cutaneous nerve of thigh.
Lateral cutaneous nerve.
What do you understand by inguinal
Inguinal is basically the post-operative chronic pain which is caused by entrapment of the iliohypogastric nerve or the ilioinguinal nerve.
Is it always
It's only by the nerve?
Need not be always entrapped by the nerve. There are various reasons for inguinal.
So if somebody has got a pain after 1 month of your hernia repair, is that inguinal or not?
I haven't read about it. Sorry.
Usually after 3 months. No?
Okay, sir.
If the pain persists after the 3 months of your
3
surgery,
months.
then you label that as inguinal and it is not necessary to be neural. It can be like osteomyelitis is there. Okay, you are taking a bite from the bone.
From the pubic tubercle.
Pubic tubercle you are taking. So that also can cause a pain there. There may be ischemia may be there. Ischemia, the cord may be there. That may be the cause for the pain may be there. So apart from the neural involvement which is there, there are the various other reasons for the inguinal hernia.
So both vascular and neural and other inflammatory reason, all that can cause the inguinal hernia.
Okay.
What is meralgia paresthetica?
It is due to the involvement of the lateral cutaneous nerve of the thigh.
So what is the difference in meralgia paresthetica and inguinal hernia? So inguinal hernia, the pain will be more on the medial aspect, around the pubic tubercle and the medial surface of the thigh. In meralgia paresthetica, it will be more on the lateral aspect.
The lateral aspect of the thigh.
What is triple neurectomy? Because some people develop the post-operative neural pain. There are some proposals where there to when you do the surgery itself, you cut all the 3 nerves. in the open surgery when you are carrying. But that is not well accepted concept, but still some surgeons are start doing triple neurectomy. They cut the prophylactically, they cut the ilioinguinal nerve, the hypogastric nerve, and gently branch of the nerve.
When you're doing the tap repair, where do you place the mesh?
In the pre-peritoneal space.
In both cases?
Yes, sir, in both the cases. Only the approach to the pre-peritoneal space is different. In cases of TAP, the transabdominal pre-peritoneal repair, TAPP, we create a pneumoperitoneum and enter the peritoneal cavity. Then we create a flap over the peritoneum to enter the pre-peritoneal space. Whereas in cases of TEP, totally extraperitoneal repair, we create a space in the pre-peritoneum, in the pre-peritoneal space using a balloon dilator.
What is ETAP?
ETAP is extended view TAP, where we place the ports of the laparoscopic instruments farther from the hernial defect to give us a better visualization and to for better repair of the hernia. The ports are usually placed in a supraumbilical position away from the hernia, giving us an extended view.
What is lighthouse? What is lighthouse in the laparoscopic repair?
Sorry, sir, I haven't read about it.
Something you look when you are doing laparoscopy, you look at something that means it is a lighthouse, and you are look at that particular point. That is the most important point.
It is a pubic symphysis, no?
Okay,
so that is in fact the first landmark for the midline. Okay, that
yes.
Looks white. So it is sometimes called the white, or it is called the lighthouse. Both the things are there for that.
Okay, sir.
Can you do open surgery pre-peritoneal repair?
Yes, sir, we can do a pre-peritoneal repair in an open surgery.
What is it called?
It's called a Reeves-Topa repair, where we do an infraumbilical incision and create a pre-peritoneal space and place the mesh.
What is pre-peritoneal space?
Sorry, sir, can you repeat the question, please?
Pre-peritoneal space.
Pre-peritoneal space is the space which contains the adipose tissue, fat, and some nerves and some neurovascular bundles, which is just below the which is just above the peritoneal cavity and below the fascia transversalis.
What will be the inferior epigastric artery will be there?
Inferior epigastric artery would be above the pre-peritoneal space, between the fascia transversalis and the internal and the transversus abdominis muscle.
What is PHS for the repair of the hernia?
Rolling hernia system. What is it?
Have you heard about that?
No,
PHS, rolling hernia system.
No, sir, I haven't heard of it.
Even in Bailey and Love.
When you're doing the open repair, you can use this. So one is a type of the inlay is there, another is the overlay is there.
Yes, sir.
So he said three things which are there. So top, connector, and the bottom is there.
Yes, sir.
What is the newer techniques you are aware? Dasarada technique?
Can you repeat the question, sir, please?
You are not aware.
Sir, can you repeat the question, please?
Dasarada technique. Where you are going to cut the external oblique upon your.
It is a non-mesh repair, isn't it? It's a non-mesh repair by an Indian surgeon.
Non-mesh repair by an Indian surgeon is the Sarda's repair.
Yeah. What is it?
So basically, it's a double breasting of it's a 3-layered repair of the inguinal region. In cases of where we basically do herniorrhaphy, first we oppose the lower lip of the transversus abdominis with the inguinal ligament, and then we make an incision over the inguinal ligament, creating two more lips of the same.
Creating on the inguinal ligament.
Sorry, sir. Can you?
You are going to create another cut in the inguinal ligament.
No, sir. On the external oblique aponeurosis.
That also you must learn the Sadar technique, shoulder technique. So non-mesh repairs, you should aware of these things when you are talking.
Yes, sir. Shoulders, Bassini, and Disardas.
If you cut the vas, during surgery, you mistakenly cut the vas, what you will do?
So we do an end-to-end anastomosis of the vas.
So if you can identify, you can definitely do a end-to-end anastomosis. Suppose you cut the testicular artery, what will happen?
So we would ligate the testicular artery.
You ligate the testicular artery. Already you have cut. So what will happen to the testis then?
Testicular atrophy. We would try to anastomose.
No. What is the other blood supply to the testis? So you must know what is Gun's procedure. So even if you cut the testis and if you are not mobilizing and distracting, there's still the artery to the vas and the cremastic artery and the cutaneous supply from the scrotum will survive, make the testis survive.
Okay.
Where does the recurrence occurs after the hernia surgery? What is the most common site after the open repair?
Over the medial
Over the medial aspect.
Medial aspect, yes.
What is the commonest open repair which is done for the hernia?
Lichtenstein's tension-free mesh repair.
So what are the basic principles of the Lichtenstein repair?
Sir, the Lichtenstein's tension-free repair usually the repair should be tension-free. There should be no tension between the two lips of the defect, and it is to be reinforced with mesh placement.
No, but what are the principles? Medially, how much you will go, laterally, how much you will go, superiorly, how much you will go.
So the defect, the mesh should be placed at least 5 centimeters in each direction from the defect. And that's the basic principle. Medially, we have to reach the midline. In inguinal hernias, the medially we should reach the midline. Medially till the midline.
Is different from when you are doing a ventral hernia. The 5 centimeter criteria is not used in an inguinal hernia repair.
Yes, sir.
So inguinal hernia, what is the principle?
Medially, the dissection should be till the midline, laterally till the anterior superior iliac spine, below till
the midline. You should not stop with the midline.
Never cross the midline. Yes.
You should cross. If you don't cross, because the pubic tubercle is there, and you should cross the pubic tubercle and reach up to the midline.
Yes, sir.
Around
1 to 1.5 centimeters from the medial to the pubic tubercle.
At least 2 centimeters from the medial to the pubic tubercle.
Okay. To the pubic tubercle.
Yes, that was because initially when the Lichtenstein described that, he was having the recurrence there about 5%. But once he adopted this technique, it was almost 0%.
Why do you want to use a mesh?
Mesh reinforces the anterior abdominal wall, and also.
Rahul, I can make an iron rod. That will much more strength, no? And some people will take a golden rod, some people will use a platinum rod, like a gold teeth.
Yes, sir. So the mesh basically is made of the mesh is used because the net, the fiber, the tissue, the biological tissue grows into the fibers of the mesh to incorporate and later strengthen the abdominal wall. And the
through. It's like a truss, like a concrete when you are making a metallic truss. So this
yes,
acts as a truss, and the fibroblast grows both through the mesh opening. So that is why producing
mesh.
fibrosis and the strengthen.
Yes, sir.
It's not the fibrosis is going to make the strength than your the mesh which you are going to put that.
Yes, sir.
Suppose you get a patient comes with after surgery, patient comes with a sinus. First is there, discharge. What are the possibilities you will think?
Surgical site infection. The wound would have
what is the definition
the
of site infection?
There will be superficial infection in the subcutaneous plane, causing any discharging sinus or a discharge or any pus discharge from the wound.
How many days?
In the early post-operative period, on this within 7 to 14 days.
You must. These all are very important. You must read SSI. There is a very specific definition when you are using no implant and when you are using an implant. So it can be up to 30 days when you are not using an implant. When you are using an implant, even up to 1 year, it can come as an SSI. So here we are talking about the mesh infection
with
and
implant.
possibilities you think. What is the commonest reason for the mesh rejection or the infection? What kind of infection will produce a mesh rejection or the sinus formation? It's always atypical mycobacterial infection. So the various steps you must see to that you are not exposing the mesh too much. Some surgery will keep the mesh open, the stop nurse will open the mesh earlier and then they bring. So all this you should avoid. With utmost care you should see to that. And once it develops atypical mycobacterium, it is very difficult to treat. You may have to even the entire mesh has to be removed.
What are the various types of meshes?
So meshes are synthetic and biological. Biological are usually made with the help of acellular human dermis or porcine dermis, whereas synthetic meshes can be made with proline, polyester, or BTFE, or
what is proline?
Proline is polypropylene, which is a synthetic monofilament polymer, which is non-absorbable in nature.
What is Vicryl?
Vicryl is a braided synthetic suture, which is absorbable, and
which
polygalactin.
So Vicryl is a trade name, no?
Yes.
Proline is a trade name. Yeah.
Yes.
What are the various types according to the weight?
According to the weight, there are low weight meshes and high weight meshes. Low weight are less than 30 kilogram per meter square density, whereas high weight are greater than 70 kilogram per meter square density. High weight, low molecular weight meshes are usually preferred to provide which provide less post-operative pain and better strengthening of the abdominal wall.
What complications can occur because of mesh?
So first of all, mesh infection can be there. The mesh can cause, the mesh has an intrinsic property to shrink. Mesh shrinkage can be there if we use an inappropriately sized mesh. Due to infection, there can be mesh rejection, and
can the mesh cause the inguinal hernia?
Placement of the mesh, yes, sir. If there is any nerve entrapment during the suturing of the mesh or the during the suturing of the mesh, there can be inguinal hernia.
And if there is no entrapment is there, it is in contact with the nerve, then also it can cause inguinal hernia.
Fibrosis and inguinal hernia.
Can it cause a sterility?
I haven't read about it.
And sometimes it has been described that it can cause even the sterility also because of the fibrosis which is opening because
You
of
are having obstructed hernia. You have an obstructed hernia, you are opened up and you may need to have resection. What is the latest guidelines on using a mesh?
So the mesh is to use of mesh is to be avoided. If needed, if it is indicated, use of biological mesh is better than using a synthetic mesh in a case of obstructed hernia.
Specifically asked you because now the guidelines is there is no contraindication for using a mesh even when there is a clean contaminant. It's a clean wound, then you on the table you are making infection. If it is already peritoneate is set in, already the strangulation is set in, then it is a difficult one. But when there is a clean wound, you are operating, all the evidence are in favor of that. And there is no biological mesh usage is almost it is now neglected. Nobody is now started using a biological mesh. So now consensus is more, you can use a mesh even when it is a clean contaminated wound. On the table you are doing a resection, still you can do a mesh.
Use the mesh.
So what is the possibility you have? Will you look at the opposite hernia? Because already Sagai sir has asked you the question. The 20% possibility.
20% cases.
So what you are going to do further?
Sir, in cases
you are talking about ultrasonogram, you must also say that I will examine the opposite side also. If there is any clinical evidence of hidden hernia or the early part of the hernia, also you can make it out of that opposite side hernia. Or when you are doing a laparoscopy, it is ideal that we can look at the opposite side very easily. You can do that. Always you think in terms of the 20%, to more than 20%, there is a possibility of developing an opposite side hernia.
Opposite side.
Dr. Kanegaval is asking us to stop there.
Yeah, thank you. Thank you, sir. Sir, we are ready. Since you are not giving the signal, we are continuing.
Yeah.
Dr. Rahul, do you have any questions or doubts to be clarified? Dr. Rahul?
No, sir. No, sir. The discussion was.
Faculty, please suggest any other questions or give the closing comments so that we can close.
Rahul has done very composed, very confident, very effectively. He has answered almost all the questions. Only anatomy part, you have to concentrate a little more because it is not excusable to say testicular artery is from the renal artery. So that's one area.
Sir, I have to brush up on my anatomy.
Brush up on our anatomy. Otherwise, you are fabulous.
Thank you, sir. Thank you.
Kanegaval sir, you are mute.
Dr. Kanegaval.
Can we call it a close, sir?
Yeah, please. Yeah.
Thank you very much, sir.
Thank you, sir.
Good night, everybody.
Thank you so much. Thank you.
Thank you, Dr. Rahul.
Thank you, sir, for giving me this
Please give our
opportunity.
thanks to Professor S.K. Tudu as well as Dr.